Good evening, dear friends of modern medicine, respected leaders of Indian Medical Association, and dear friends. Hearty welcome to Indian Medical Association College of General Practitioners, Kerala chapter. As you know, the state president of IMA Kerala State has put forward a grand theme, empowering healer, enhancing healthcare for this IMA. We are immensely grateful to the state leadership for saying. We start the program with heartfelt gratitude to our beloved state president, Dr. M.N. Menon, and our beloved vibrant state secretary, Dr. Roy R. Chandran of Indian Medical Association Kerala State Branch. The support we are getting from IMA Kerala is immense for this venture, as well as many other interventions of IMA CGP Kerala across our state. Friends, now we have started this journey of empowering healer and enhancing healthcare through an empowerment in every sense. Practically, we have given we have started off with a WhatsApp channel, which is still working with important update on every day, almost every day. And you can log into the, IMA Kerala state CGP WhatsApp channel through this link. If it is available, also available in your WhatsApp groups, please make use of that. Then, kindly share. See, anything will not be perfect without contribution from everyone. It's a teamwork. Together, everyone achieve more. So kindly share your views, how the IMA CGP should contribute more, how we can make our efforts more effective, how we must reach out, and what are your, the topics that you want, whatever you want from IMA CGP, please share your views at imacgpkerala@gmail.com. Friends, we started this journey of essentials of every day in modern medicine with a weekly webinar series from 4th June. And we traversed many topics. And there are a lot of search requests for YouTube links. We are really proud from across India. And that means that the program is reaching the hearts of really intended people. And we have a very good news to share you today. That is, we are conducting this weekly webinar with the same username, that is same passcode, same ID, and the same link, and almost, we do the YouTube live stream as well. With the most relevant topic, faculties across India, across our nation, and it is useful for any doctor. We have been discussing single topic in a day, okay? And we are going to have a conclusion of single point topic discussion today. That is with the primary care in emergency medicine. And that I'll come to. And before that, next week onwards, we are going to come with a very slightly different agenda. Like, we are going to come with a grand rounds team. 2 or 3 or sometimes 6 or 7 faculties will come on a particular day. We'll spend time together from 8 o'clock till about 9:30, but we will cover a very important segment of modern medicine with an extensive array of faculties. For example, next week, we are going to cover the management of cancer in primary care. 6 or 7 faculties coming. We'll discuss each essential aspect of oncology, what every doctor must know. And subsequently, we'll come with a session on addiction. How a primary doctor can manage addiction of tobacco, alcohol, or even drugs. And subsequently, we are going to come with ENT, ear, nose, and throat in a day. And then we are going to come with first MBBS revisited. The clinical chemistry, essentials of anatomy, essentials of applied physiology, and all. So please join us. And then we'll have a grand session on diabetes, primary care of diabetes, prompt management of diabetes. Then there are many things in this area till the first week of November, when our beloved Krishna Kumar sir will be taking over as new director of studies of IMA CGP, expecting another era. Friends, this is time. This is time for us to listen to a great giant. If there was this leader in emergency medicine, the history of emergency medicine across the developing world probably, and particularly in Kerala, would have been different. And there won't be this much birth of emergency medicine doctors. And I think Kerala and the nation should honor Dr. Venugopalan PP with the most available, award or recognition, because he is not behind anything like that, but he's a man where he will be reaching to anyone who is interested in learning primary care or not only primary, advanced emergency care. And so I'm so happy to have Dr. Venugopalan sir. Now I welcome Dr. Biju Nelson, our State Secretary of IMA CGP, for formally welcoming and introducing our beloved faculty of the day. And your presence makes, the topic will appear, okay, how we are going to manage primary care doctors are going to manage an emergency situation, that will go to the trauma care. That you will understand when you listen to Venugopalan sir. And before that, over to Biju Nelson, Dr. Biju Nelson.
Okay. Good evening, Director of Studies, Dr. Prashant, our Speaker of the Day, Dr. P.P. Venugopal, senior IMA leaders, senior colleagues in Indian Medical Association, and dear friends. It's my proud privilege to introduce the distinguished speaker for today, Dr. P.P. Venugopalan, Senior Consultant in Emergency Medicine and Trauma, Meitra Hospital, Calicut. Dr. Venugopalan PP has completed his graduation from Government Medical College, Calicut, his post-graduation in anesthesia also from Government Medical College, Calicut. He had his DNB in emergency medicine, as master's in emergency medicine from George Washington University, USA. Dr. P.P. Venugopalan is a pioneering figure in emergency medicine in India, widely recognized as the father of emergency medicine in Kerala. With over 3 decades of clinical, academic, and administrative experience, he has played an instrumental role in shaping emergency care systems across India, establishing postgraduate training programs, simulation centers, and large-scale public health public trainings like the Angel EMS network. A decorated educator, published author, and a national awardee, he has wide knowledge in advanced airway management skills, acute and chronic pain management, resuscitation training and research, trauma care, pre-hospital care, ambulance networking and EMS training, disaster management and training and empowerment. It is indeed an honor to have such an accomplished emergency physician and teacher with us today. On behalf of IMA CGP, I warmly welcome Dr. P.P. Venugopal and request him to take over the session. Thank you, sir.
Thanks a lot, Dr. Biju Nelson. I would like to add one more sentence. Like, sir, Venu sir, actually, we, and my words are to everyone in this crowd. See, we usually cross 100, 150. Now we are about 50. I think it should go by. But still, it means that people think that emergencies will not come to primary care. And I am sure this YouTube link is the one which is going to hit the max, because once you listen, you will understand. So my humble request to everyone in this gathering is to share the YouTube link, which I'll share, please, with every doctor. Because if you don't know how to manage an emergency, we are never a complete doctor. And with all the, regards to a great leader, and a great philosopher, and a great human being. His conduct in Calicut is Calicut's cultural heritage, Calicut's medical heritage, everything. Venu sir means Venu sir. Sir, with utmost respect and love, we welcome you. Thank you, sir.
Thank you, Prashant ji. and Nelson, Biju Nelson for the overwhelming introduction. And definitely, I am so privileged to coming to this forum. And I know this forum is doing great work in various way. And very recently, we just completed the South National Conference in CGP in Calicut. We all met together. Okay, anyway, I'll just share my slide. All of you are visible to my
Yes, sir. Yes.
next slide. I am definitely this time may not be too much focusing on the CPR skill and airway skill, that kind of things, because already IMA ELS is doing tremendous work across Kerala. Huge number of training is happening. And I will touch in between some of the core areas. But what I am trying to focus in this particular session, that is emergency medicine is not only managing emergency skill, but it is beyond that. We have to identify the critical situation, and we have to connect, especially primary care. It should not miss the time in between. So all there, and at the same time, our urban Kerala, probably the metros Trivandrum, Kochi, Kozhikode, and even now the Kannur, Trichy is all fast growing metros. And these metros have that emergency care is reasonably good. And I was there in this emergency care since 2005 onwards. That is a long 2 decade. And those time when I was here coming into or jumped into the area of emergencies was a just casualty. And then that just casualty, people will are looking at just why this man or why these people are doing like that. Now that a lot of changes, we have like a national training program, international training program, short courses, long courses, so many things are there. And even if these metros or the cities are is a reasonably doing well in emergency care, but when you are looking to the primary care, particularly rural Kerala, situation is not so good. Still, we have to do a lot. And this presentation, I'll focusing on a little bit of or an administrative emergency care as well, because even if you know the stuff, but if you are not presenting or in not presenting properly in front of the government authorities, or even suppose now I'm working in a corporate, even in a corporate, if I am not presenting properly the need of the things in front of the top authorities, we cannot do much. Probably you want to do something, you will be urged to do that, but your hand will be tied. And this is something I am trying to bring, particularly again, all the senior IMA and other people are listening this program. How IMA can do much more and get into get to establish a rural emergency setup at par with whatever the current evidences and what the other states are doing. And like that, I'll just quickly go through this. And also, this is not merely a lecture. It will be a interactive session. In between, I will give opportunity to interact, taking the new gadgets. So maybe the next slide, all of you should scan. You open your mobile and scan this. Just scan the QR. When scanning the QR, you will get the there is a then like, a QR can, and then you can get into this site, and you can just scan itself. You can get into the Slido site, and then if it is not getting, you just enter this is the slide, this session code, and once you get it, just type try to answer your answer and upload, just to post it. Which word best describe your biggest hope for emergency care in Kerala? This is what you are seeing in the screen is just I did a sample testing. Whatever you are testing, that will come, that text and post that will come in the screen. Someone is posting. Are you able to do that?
Yes, sir. Yes, sir. I did it.
Okay.
I think many of the people are doing it through the mobile, sir. This attending the Zoom
Yeah,
through mobile.
mobile is one comment is coming efficient. One person is coming, yes. Another timely response. This is a way it is coming. And idea is like, the listener should not be asleep. In between, certain things will come in the subsequent. There are 4-5 people are responding. Your responses are appearing on the screen. You can also see the response, All of you can see that?
Yes, yes.
Yes. Quick response, good, urgent. These are the things our audience thinking about when asked them to describe in one word or the best to describe the emergency care. Anyway, I will move to the next slide. We will get more this thing, and you can keep yes. Again, one response is coming like promising. Future health. Great, very great. I'm happy to see that interactiveness in between. Ready to help. So yes, you people are, this is our expectation exactly about the emergency care. Yes, then I will just moving to the next slide. Okay. I will just quickly while going through this session, I will just briefly tell you in 4 major quadrants, the burden. What is the a burden of burden and gap? What is existing in the structural weight and time critical morbidity? Especially Kerala, we are doing that Ardram chronic care. There is a blind spot there. I'll just bring it to this in the subsequent slide. And again, how we can make it how the emergency care, WHO and other national standards can be bring into the in our Kerala setup, like in a five-tiered method. Again, I'll also quickly go through minimum viable packages, how the facility engineering, how we can do, and how we can to connect that Canive and other transport system to improve our emergency care, or whatever any lacunae is there, or how the beat can be re-altered. And also some something is essentially required in our scenario, that is the implementation of the hub and spoke model, particularly in a geographically challenged places like Wayanad, Idukki, etc. These are and how the manpower can optimize like that. Because I am talking all this because this is the IMA is the organization that we can do a lot, and we can negotiate with the government and other authorities to bring the high rent emergency care that is accessible to everyone. Just listen this video, how the gaps are
Kerala
happening.
is India's most invaluable health records. Life expectancy here leads the country, while
Audio is okay for everyone.
Sir, audio is working, video is not working.
Video is moving. Video, you can see the video.
See, we can see just an image.
It will move subsequently.
infant and
Okay.
maternal mortality rates
Okay.
are the lowest. For decades, these metrics have defined the state as a leader in public health.
You can see it
The
now.
nature of the threat has changed.
Yeah.
As the population
Okay.
ages, mortality is increasingly driven by sudden, time-critical events: acute heart attacks, strokes, severe road trauma, and acute envenomation. Take road trauma. Kerala is defined by ribbon development, continuous urban sprawl along highways. This density forces high-speed transit to share space with pedestrians and local traffic, creating a crash burden dispersed across thousands of miles of rural corridors. Because emergencies are so geographically scattered, the closest medical facility to a dying patient is rarely a high-tech tertiary trauma center. It is a local, rural primary clinic. The state recently upgraded hundreds of these rural clinics into family health centers. These facilities excel at managing long-term chronic disease and preventive care, but their design leaves them ill-equipped for acute trauma. Systemic failures in emergency care follow the 3 delays model. A patient might recognize the symptoms and even secure a fast ride, only to reach a clinic staffed by a single doctor without a triage protocol, a crash cart, or the necessary life-saving drugs. Solving this 3rd delay requires no massive new hospitals. Instead, it requires engineering 4 specific pillars of emergency care directly into the existing rural frontline. A patient's chance of survival is dictated by the system architecture operating within the first 60 minutes, regardless of the specialist hospital they eventually reach. We can trace this system through a single case. A 52-year-old rubber tapper working in an isolated plantation feels a crushing pressure in his chest, an acute heart attack. The clock starts now. This is Pillar 1, scene care. At minute 0, the crucial actors are not doctors, but bystanders, taxi drivers, and local volunteers. Intervening is often a legal risk. While Supreme Court guidelines protect Good Samaritans from liability, nearly 3/4 of citizens still refuse to assist crash victims, fearing police interrogation or hospital fees. To bridge this gap, the system trains trusted community figures, like ASHA health workers, in basic life support and symptom recognition. When these local networks are activated, they recognize the emergency and seek professional care immediately, ensuring the golden hour begins with action rather than confusion. At minute 10, Pillar 2 arrives, transport. This is handled by the state's Kaniv 108 ambulance network. However, the fleet faces strict limits. Every vehicle operates strictly on basic life support. Furthermore, at 8 at night, when crash severity typically peaks, the number of active vehicles is halved. To maximize these resources, the crew uses a zero-cost intervention, pre-arrival notification. They radio the rural clinic to relay vitals and an estimated arrival time. Without this step, an ambulance functions only as a fast taxi, delivering a dying patient to a room that isn't ready to receive them. By minute 30, the patient reaches the rural clinic. This is Pillar 3, facility care. Here, the clinical objective shifts. Staff must diagnose the specific emergency, initiate time-critical therapy, and coordinate a safe transfer. Readiness does not require massive capital investment. Reorganization delivers the highest early gains. Establishing a fixed triage point, maintaining a sealed crash cart, posting laminated algorithms at the bedside provide the foundation for survival. But a significant hurdle remains. Expecting a single rural doctor to interpret a complex ECG and authorize dangerous clot-busting drugs in isolation carries a high risk of error. Pillar 4 solves this through a hub-and-spoke telemedicine network, digitally tethering the rural clinic to a central hub of specialists. As this chart shows, giving rural doctors cloud-based diagnostics and expert backup drops inappropriate intervention rates to nearly 0. The rural doctor no longer works in a vacuum. In a crisis, their clinic becomes the physical extension of a statewide expert brain. This integrated 4-pillar response replaces chaotic ad hoc referrals with choreographed clockwork precision. The impact reaches into the state's economic stability. Investing in the golden hour serves as a direct safeguard against household financial ruin. When the system prevents long-term disability through early intervention, it stops families from falling into catastrophic, bankrupting medical debt. This protection is vital in Kerala's geographical extremes. In the steep high ranges, or isolated coastal backwaters, the physical terrain makes long transport times unavoidable. Because geography is fixed, the only way to achieve equity is to push higher-level first contact capability deeper into these remote clinics. Emergency care is the ultimate test of health equity. By fortifying the rural front line, a society ensures its safety net catches everyone, regardless of where they happen to live. Kerala holds India.
Okay, now just another poll. Just to the poll. I want to know your thoughts. Just poll it and it will appear your thoughts here. Sorry, I'll go to the back slide in between. Yeah. Yes. But only like, a few more. The poll is in like, 50% of the people are familiar with the Kerala Emergency Care Network today. And 30% is about somewhat familiar. And again, 20% of the people who participate in the poll are even not hearing. Right. Yeah, that is increasing, interestingly. Yes. But this is the situation, what we have to be. Anyway, I'll move to the next slide. So whatever I shown in the video, this is the nutshell of what I'm going to talk here. You can see, like, there is a Kerala paradox, the Kerala paradox conventionally that what we have, we have our standards of healthcare is shows like high life expectancy. We have institutional delivery, low infant mortality rate, low maternal, this is all we know. And at the same time, the other side, there is, about the acute reality, about the emergency acute reality is concerned. Our state is India's the highest number of oldest population. Our aging number is increasing. And also we have, if you ask me, the Kerala is the international capital for the lifestyle diseases. That's why we have that heavy time of the critical lot of morbidities are there. Diabetes, hypertension, coronary artery disease, all there. Again, about 1.82 crore registered vehicles are navigating through the Kerala roads. And most of the Kerala roads you can in other places a very ribbon kind of things. So the Kerala has finished the demographic transition, but its primary health network must adopt a structurally heavier acute care reality. That is the core statement we have to do. And then when we are mapping our our situation or special situations in Kerala, and what all the things that we can do, like that, definitely, road traffic accident, daily 133 crashes. This is an average. And about the 2024 strategy shows that nearly 50,000 crashes per year. And so, about this fatality about this, total issues, nearly 56, more than 50% of the fatalities are from the two-wheelers creating again there the age group is between 15 and 45. And what is we have to be quickly required, facility to do an early airway management and also to hemorrhage control. These two things will kill the patient. And about the acute coronary syndrome, our mortality rate is 8.2%, and also this is all these mainly 20% of this due to a delayed revascularization, either thrombolysis or whatever kind of not accessible to thrombolysis. And only if the 41% of people are receiving a golden hour thrombolysis. What is required is, again, it is the identification with an early ECG, early exact diagnosis, and reperfusion strategy. Another specific things what is in Kerala is in envenomation and toxicology kind of things. The people in the rubber plantations, then our paddy field, particularly the Russell viper bite is very common in our state. And also the people are consuming the agricultural chemicals like OP poisoning, etc. Again, where it is required, early we have to do we have to empower and make sure that it is happening in our primary cares into the immobilization, early ASV administration, then decontamination, and without delaying atropine kind of things. Again, we have the environmental and environment related trauma also there, particularly, there is backwater drowning, floods, again, the wildlife interface, particularly in Wayanad and Tidukki. This is very common. Now, every day we are opening the news, you will getting someone is attacked by wild animals, Kaduva, then elephant, tiger, all these things are there. Even the, or different kind of things we are now. And also what we need, early rescue breathing facility, training, and the mass casualty trials that we required to overcome this, at the critical first contact intervention. These are the critical first contact intervention. So why the rural emergency care is delayed sometimes? There are, when going through the literature and other things, I identify three issues, three delays, which is which will cause delay to deliver or to get the emergency care, particularly in rural emergency. One is classical one. First one is a delay in decision to seek care. There is a first and foremost delay. This is, why? Classical example, symptom literacy. For example, if someone is suffering from a chest pain, and immediately they will think that it is a gas, just a gas. And then finally it will end up into a complete cardiac arrest scenarios. And also sometimes financial anxiety is also one factor. The second delay is reaching a facility. That is particularly very important for Idukki and Wayanad terrain, and also in Kuttanad waterways, and specific again some area the traffic congestion and ambulance gap. Then we have nearly 350 canoe ambulances. At the same time, in Kerala registry, ambulance registry has got more than 5,000 registered ambulances in the state. But these registered ambulances, some of them are working hospital related, some of them are mere dead body carriers, and some of them are merely keeping an ambulance somewhere, but not a proper. Even IMA tried and Angels tried for a networking all this for this kind of ambulance, but it is not got it in its a real meaning. And nowadays, the private ambulancing is a bit of tough to network and all. When we start Angels and all, those was easy. But now it is not so easy. And the third one is receiving care at arrival. This is something like, delayed things, sometimes like, they absent proper triage, even a single doctor in the night shift, missing an ECG, and also difficulty or the in the secondary transfer, or there's a delay in the second. These are the three major area which increase our morbidity in the rural area or in the primary area. So the most systemic intervention to date have focused on delay to is again definitely I mentioned is an ambulance, and the largest remaining margins are again so community education, activation, again first aid awareness program, again again the referrals, how the referrals is happening in our area. Someone is referring to a higher center, even in a medical college or in a district, because people will just come whatever the vehicle is getting and land up in a tertiary or the secondary care or district level hospital. Even the doctor or the people sitting in the higher center, they are not aware. They are knowing but this is quite possible. A primary care doctor can do a proper referral note and just communicating and refer it is probably the tertiary care can become more prepared. They can be better prepared. They can do a better preparation to receive the patient, to give and to save the time. When an emergency strike, something is like emergency strike, our clock. Usually our clock will run in clockwise direction, but an emergency strike, the clock will start running in an anti-clockwise direction. It is something like you are playing a video game. And a certain point of time, this clock will stop and the game over and everything is kadam ho gaya. This is the things will happen. So this is the something, you look at the Ardram government project, Ardram, there is a gap. There is an engineering blind spot in the Ardram project. Ardram project Ardram Mission Foundation has established 750 family health centers. There is established OP from 9 a.m. to 6 p.m. And also they place that LSG governance, etc. So what you are looking at this, looking at the comprehensive primary care, this is the base is this, and then there is a top that is holding the Ardram project with the 3 pillars now. That is attending the chronic care, promotive health, and preventive care. Definitely these are good, but in one more pillar, that is acute time critical care, that is to be incorporated in this to fill the gap. Then yes, the design, this exactly I mentioned. So the facility of emergency capability was never a defining pillar and it has to be redesigned. It explicitly left out an acute time critical care. This you just keep in your mind. Another poll. You can write down whatever your thoughts, you can write down, it will appear here. What is the single biggest gap in emergency care where you are your work? No one is responding. All are left, no? Yes, it is coming. Overcrowding. Yes, it is a big issue. All kind of patients will, yes, lot of thoughts are coming. Expertise of health workers That is the lacunae. Few people are thinking. Again, delay in investigation, training for update, overcrowding, knowledge base enhancement, lack of awareness. It's a fantastic response I am receiving, I'm getting from the audience who are listening this. This is exactly what all the points that you are mentioning here is absolutely true. I deeply involved and worked in even it is true for whether in like in a corporate, in medical college or in district hospital. Yes, I totally agree. I like to agree and with your thoughts. Probably we are focusing. These are the area definitely Prashant can note it these are the area we even CGP even IMA we can do many things and definitely yes. Right. Society is not aware of, but yes, exactly. That is the biggest issue. Everyone will land up. Again, the priority or the emergency priority for the people who are landing up is also different. We may think like the heart attack, cardiac arrest are the priority as an emergency people, but the people coming there, even a small injury or to moving or to next marriage function, these all their emergencies. This is creating a lot of problem. Even we are putting the triage, people may not be understand the importance of triage. Even after so many years we are working, still the people are thinking about this kind of this is a very good cross section of the lacunae. These are the where your centers are working, you are facing it exactly. It is a cross section. It is not only in primary care, even middle care or in tertiary care or quaternary care. Fantastic response. Thank you. I will move to the next slide. We have how to translate we this our system into again whatever the things I am putting is a from published data, and I also in between I am adding some my personal experience purview also. One there is a WHO emergency care framework is there, which include a scene care, enhancing that domain work on scene care, transport, facility care, etc. Again, IPHS. This is the Indian Public Health Standards that is placed in 2022. This is target 50% of facility compliance. That is this standard is this is something like these standards are like our NABH accrediting standards, etc. These are already there, and again there is a rural health center PSC must this Indian public health standard is saying our PSC should work around the clock with the stabilization capacities. This is the place national level. These standards are already there. Still, we are not reached that level. There is a we are even less than 50% of the competency we are reaching. Again, there is a national quality assurance standards NABH and other etc. Again, there is a in Kerala itself there is a we have 290 national quality accredited centers in Kerala. That is a very good thing. What the accreditation standards is emphasizing on placing a triage protocol, sealed cards, crash card, and making the availability of emergency drugs. These are all something, the very minimum things they are asking, but we can do that. Yes, how we can move to this 5-tier system? What we have to do in the level of community, particularly there's a first 10 minutes at the bottom of the stair. In the first 10 minutes, we have to, at least our bystanders should able to do, or our people or either in healthcare or whoever is witness something in a cardiac arrest, they should be able to do the hands only CPR, compression only CPR or the hands only CPR. Even that is enough. If you don't know much of this, at least give CPR. Someone is in arrest, someone is not responding, someone is not pulse, even not the public pulse is not required, someone is not responding, not moving. And they should initiate to the CPR and also the bleeding control in a trauma scenario. Bleeding control is nothing very complicated. At least you give a compression, just a pressure over the bleeding points. And okay, then in the primary level, an administering drug is not an issue. And coming to the next level, like in SSC or the in the next level, another 10 minutes, we have a small center, small health center. They should able to triage the patient. They should able to give, there is a facility, should be like, oxygen. Again, at least IM adrenaline possibility to be there. So I'm talking about very minimum. We can go beyond. And moving to the family healthcare facility or a PSC facility, that should work. The third stair, that should work 24 hours. That is not happening in our, where there should be the provision for backwash ventilation and to be a tele ECG, aspirin loading, again anti-venom. All the raining and all certain, even the post flood and all, how much bites are happening in Kerala. And a delay in ASV is a problem. Again, in the fourth level, that is the CSC or the block FSC, where I'm mainly focusing like in a government kind of things. Definitely, this is otherwise like small one doctor clinic, again a small 10 bedded clinic, then a 50 bedded hospital. This way you can think about when coming to our private, because in Kerala is Kerala healthcare is not if Kerala healthcare minus private sector means it is a big gap, something, so that also will be there. Again, again, I'm talking about the documented, published document basis on the public documents. Again, where that CSC and all, we have the provision for endotracheal intubation. Again, there will be provision for thrombolysis for a cardiac event. Again, need at least a blood storage area. Then only we will able to manage the trauma and other things. And coming to the level 5, the district hospital level or the other tertiary level, where should be a full-fledged ED, CD, cath lab, definitive care, trauma. So this is a way the system has to be moved forward. Prashant, when I should stop it? Another?
Sir, not a problem, sir. You move forward. And then there are
another 20 minutes?
Yes, sir. And towards the end of this thing, we expect you to tell us what a general practitioner do in some critical moments.
Sure.
Sure.
This is sure. This is also in between I am telling going on. Okay, fine. Okay, right. So what is our old thoughts was stabilize and refer, and blind and is undocumented referrals, defensive medicine for the fear of litigation. But what is the new one? You have to be even in a primary doctor, you should have a active protocol-driven timely critical therapy, and also required structured destination of destination mapping, and also connected with the tele support. At least like a 12 easy. This is a primary care. How this is not about, I am talking about a big facility. It's a small blueprint for a small clinic or in a primary health center where there is a 360 degree resuscitation facility, where a small triage area. There are also a a crash cart, and also we should display the essential algorithm in your primary care, how suppose a cardiac arrest to be managed, and how this is, because this is already reckoner, and even anaphylaxis coming, what the first step you have to do, anaphylaxis, basically the drug is adrenaline. Without adrenaline, our will CPM, Avil, and other Dexona, or the hydrocodone complex issues are in a real established anaphylaxis, it will not work, where epinephrine is the choice, because this is the physiological antidote for the histamine. And also, if you have a dedicated ECG, tele-ECG station, if it is a coronary event, if the primary doctor has a doubt whether it is a ST segment elevation or it's a non-STEMI, they can just shoot up with whatever the tele-center that you are attached. And they can also read, they can tell, okay, you load it from here, aspirin, and copy doctor here, and then shift it. That kind of things can be done. Because this is all like, this much facility is enough. The crash cart, which include whatever is in a monitor, a defibrillator, oxygen section, and all the critical emergency drugs. This will save many of our patients. Don't worry about legal and other things about the resuscitating a patient. Another yes,
Alright.
quickly respond it. Part of emergency network should be strengthened first. There are few things are there. What do you think? Which part ought to be addressed first? Probably your response will be very useful for Prashant, and he is the state leader. He can, yes, brilliant. But only one person is responding. Few more people are coming, then only will triage and transfer. Communication system. I'm happy to see that you are all with the technology. You are with the technology. It's good to see, like, Prashantji, this is a real eye opener. How the real people are thinking, they are sitting in their places. What is the real problem they are facing now?
Absolutely.
That is the reason why I put it some polling. The 55% all people are thinking like what triage and transfer is the major issue. So through that we have to address it. Even the total poll number is less, only 11, but still this much polled people are thinking. And another good number of people are thinking like communication system to be improved. Then specialist access is also a problem in rural care. Because many people who may not be very happy to go and serve the rural population with someone is a PG degree and post PG degree, etc., where probably our telemedicine facility will help you to augment it further. But no one is thinking about ambulance is not a problem. So what is the essential equipment should be there in your emergency room? Definitely this can be like structured or keep like that in an airway, breathing, circulation disease. So when you are setting your emergency room, you need a back mask ventilation, intubation facility if possible. Again, laryngoscope. Then even if you are not if you are not able to intubate, there are provisions for quickly control the airway, like laryngeal mask airway. Even another airway called LM. King's Airway. These are like blind insertion devices. You need things like the OPA, NPA, and oxygen cylinder suction. There will be suction, but sometimes it will never work, and because these things to be checked in every day. Oxygen flow meters, tunicate, yes. Nowadays, there is a hemorrhage control. Even a trauma is coming. Previously, we teach you people like an A, B, C, D, E, airway, breathing, circulation, disability, like technique. Now the current guidelines is like X, A, B, C, D. Even before starting your airway intervention, you have to address the torrential catastrophic bleeding that is being done by the direct pressure. And also you can do a direct pressure with your gauze or like in a clean cloth, whatever what you can use. And also even the bleeding is extravasating, even the tunicate is there are a glass lined tunicates are available name here. Again, the disability is not only fracture, is a neurological event. And also, if the patient with a pelvic fracture, if you are referring a pelvic fracture patient without a pelvic binder, the patient will die in between, because a pelvic fracture in a trauma, it will lose almost more than 50% of his blood volume. 2 to 3 liters of the blood volume will lose internally. So a pelvic binder is simply help this. Definitely for the diagnostics and is concerned, the tele ECG, again the point of care ultrasound is no longer something yeah, this is something like a stethoscope. Yeah, it is a visual. This is replacing our stethoscope. According to me, the stethoscope which will not help much. Only thing you can do a stethoscope. Otherwise, the public will not say he. Even suppose I am attending a patient without stethoscope, people may think he is not a doctor. Otherwise, the role of stethoscope is totally taken by the point of care ultrasound. Definitely, and this what is the governance rules? When equipment list is fiction without named custodians, daily shift-wise check registers, again tamper, evidence seal on the crash. It's all will be checked everywhere. Sometimes it's all placed, but no one to look after this. These areas to be addressed. Say formally, our ring fenced formula is a green in green Kerala, where what is required is our place as far as the emergency care is concerned. We need a sealed medicine cabinet. There are at least 3-4 things. One is the cardiac medicine, essentially neurological medicines, then toxicological medicines, oxygen medicine should be a kit, sealed medicine kit, which is cardiac, particularly aspirin. The sorbit rate and all is out, Previously, everyone will give the sorbit. Sorbit rate issue is if your patient is a myocardial STEMI or myocardial infarction, particularly this is affecting the inferior wall. Inferior wall, if you give sorbitrate, the patient will going for further hypertension. Where the safe drug that you can give in the primary level is aspirin and clopidogrel. Definitely adrenaline in cardiac arrest is the magic drug, that is the Mrida Sanjeevani. Toxicology is ASV, giving ASV, and then bulk for the opioid poisoning. Not 1 ampule, 2 ampule is not enough. You have to keep it this is a vial ampules are bulk atropine is required for reversing the effect of opioid OP poison, the organophosphorus poisoning. Pralidoxin, okay. Particularly neurologically, we cannot at least diazepam, midazolam, or Levit dropel and all. These are basically to someone is coming with a convulsion and all. This will be help you. Obstruct is definitely something people are very afraid to think it, but you need oxytocin like magnesium, etc. is be required. And this replenish and it's a checking protocol is all very important. Transport link, how we can do in our ambulance, we have in 135 canoe ambulances. They have a central dispatch system. All the ambulances are sometimes some issue with this canoe ambulance system. That is one way we have to address again. That is all of them are fleeting BLS ambulances. Few, I don't know the ALS is there. But the night capacity, only 50% are working on night. And again, some geographical mismatch in their allocation is also existing. Probably we have to take this in the government level. These are everything is I'm talking about the published data. So how to some of the training programs, how we can training the community, ASHA workers, etc., etc. Again, this our IMA is working. We are all working for the ASHA and other community. We can do a first responder training, which include the CPR and bleeding control, and they should also go for a 12-month. This also a primary people should know, and the police other people they have first responder training, mid-level health providers. This is a BEC is a WHO approved emergency training program, but we can do our own way. But this is the documented one. All staff nurses should undergo national emergency life support. There is also central government government of India is already placed that training module or the BEC. All the medical officer in T2 and T3 level should be undergo ACLS or the national emergency life support. Again, they should be trained in tele ECG. Also should be focus, etc., etc. Again, all EMT worked in canoe and also ambulance drivers should also be get trained national life support level. Certain things about the training. So we are training alone is not enough. If you're training, they will forget, and after training basically training is equal to people thinking like in a certificate. But beyond that, it's not only training alone will not make much outcome. What we require training plus protocol into a tele decision support plus 24-hour public. That will create a outcome, a change in the outcome. There is a proven published data from Himachal, even Goa, even in Tamil Nadu. These are Kerala. We don't have any documented published things. I didn't get it because this states can do. Why we know? Why don't we? We can do very well all this. There be the triage protocol. Usually this AIMS approved triage, or just use it at 3. Your even if it is in the small center, do a 3-level red, yellow, green triage protocol. And also also you put it, as I mentioned when talking about the ED small model, we have ABCD primary survey, adult and pediatric BLS, STEMI, stroke, OP poisoning state. This algorithm to a ready quick reckoner, you need not be worried about, need not be go and refer. You can see, look, this to be displayed in your emergency room. And one rule is governance rule. We can do the triage does not exceed unless performed by named, restored, trained person at a fixed point with the documented categories. Yes, one more poll, Julie. Maybe 1 or 2 poll and a few more slides. I will quickly finish now. How feasible do you think the blueprint for Kerala is right now? Is a score of 1 to 5. 1 means not practical. 5 is extremely practical. Yes, it is feasible. People are something like a 50-50. Most of them are thinking okay, 14% people are thinking about it is absolutely possible. At the same time, 40% people are thinking about it is very difficult. But 50% or people think it is optimum. It is grade 3. And okay, it's a good 44 plus 11 plus 33, nearly 80%, 90, nearly 90% people think the blueprint is possible and we can implement in our state. That is a good thing. Great. So how to be the referral? Suppose you are referring someone, something there should be a feedback loop to be completed when you are referring a patient to your higher center, wherever it is. First of all, the destination matrix means the you fix it where it should be send it. You have to send it a predefined facility where whenever the people can manage this. It cannot be do just a guesswork, because particularly in time sensitive cases like coronary syndrome, stroke, sepsis, this is all like time sensitive, that you have to be reached in a facility where they should be able to handle it. And also the handover is something like, just like I am not like I am sending a patient അങ്ങോട്ട് വിടുന്നുണ്ട് അതുപോലും പറയില്ല, just people are just came through over whatever the way. Some patients are coming just quarreling with the primary center and then coming and turn out like that. So what we do, like, if you are giving a handover that is given to the referring center, like HESBAR means it is a situation background, then this action plan that you did it, and R is reflections. These all like, this will is a composite form, standard form, how to do the verbal or a written clinical communication. These are all relevant whenever suppose you get into a medical legal issue. So people will cross it in court. How did you refer? You call, you made sure the availability of the facility there. Again, your referral letter, this all make valid. And again, this is a pre-arrival notification. This is absolutely, this practice is almost zero in our state, even if our state is very good and number one in health. And this is the because you give a pre-arrival, suppose you are sending a medical or wherever it is, should be like, a pre-arrival notification, like, it is again, it is not a courtesy, it is an essential mandatory. And the transfer record, give the transfer record, you are finding ECG, whatever the things to be transferred. And the loop and receiving facility should be like, give to the give to the loop to give that primary physician to give your patient receives. These are things. Then these are there, means you both this is a win and win situation for the primary doctor, mid doctor, or the doctor who are working, or the facilities are working in a higher end. About the legal issues, people don't worry about like, if you are doing a bystander CPR, are you or something you are doing in the primary level with the best interest of the patient, that you will be like, penalized. There is a good Samaritan law guideline is already there, is in the Honorable High Court. And but interesting things like, 75% people are not doing the bystander intervention because of the reluctance to assist, because of the main issue is the fearing about the legal harassment and the court appearances. And another big clinic verdict coming from West Bengal, that is not the West Bengal, this is another place. It is even in 1989, this mandate shows the professional obligation to preserve life, enroll all medico-legal formalities, and care explicitly proceed police framework. But you don't worry about to give, because none of the medical obligation or legal obligation will come on you if you are treating and saving a patient in an event of an issues. So this is something like a model of the hub and spoke model, where, like, the from the periphery, the spoke, they can communicate to the tele support, and they can 24-hour tele support through the connecting with the specialist. They can also guide them whenever the people sitting in the primary care are feeling like, some difficulty. Definitely, we can use the new technologies like, our AI and all can be help all these. If you are planning to implement this or giving to a project for the government, it should be a phase manner. Probably like, in phase 0, there is a basic baseline tools. This is like in a phase 1. We will do a zero cost win, like establishing the triage algorithm, crash cart. This is all the phase 1. It will take make 1 to 6 months. initially to prepare all the project and all, you can take 1 to 3 months. That is a phase 0, and phase 1 this way, and phase 2 this 3 months to 12, where the capacity building and training, which include that ECG tele deployment, again national life support training, BLS and other things. Phase 3 definitely integration, whatever the STEMI pathways, again closed loop communication, this is all to be done in the state. This will take another 9 months to 18 months. And the phase 4, 18 to 36 months, where there is a emergency certification of the centers, make sure that the audits like that. About the finance is concerned, for the government research, there are there are NHM fund for the training and equipment. There are state plan Ardram fund for infrastructure development. Again, LSG Panchayat funds are there for to getting consumables and local drug. And again, Ayushman Bharat is a big amount, 65,000 CR is there, and Kerala is not utilize this. Again, the cash fund. For the definitive care reimbursement, again for the tele infrastructure A and other thing, we can tap the CSR fund. There will be there is a key performance index board, etc. We have to keep it and to be monitored. The metric standards like access, pre-hospital, etc. Various standards. You have to fix it, then only it will work. Otherwise, with enthusiasm will start and it will not work. One more poll. This is just what one change would make biggest impact in next 12 months. Suppose 12 months. If you are putting this, probably you will be confused. നമുക്ക് അടുത്ത ഒരു 12 മന്തിൽ എന്താണ് ബിഗസ്റ്റ് ഒരു ചേഞ്ച് നമ്മൾ വേണ്ടത് ഇൻ ദ കെയർ ഓഫ് എമർജൻസി കെയർ എന്നുള്ള ഒരു രീതിയിൽ എൻ്റെ ഒരു ഉത്തരം നിട്ടാൽ മതി. People are not much response. Maybe this is very difficult a little bit. Then I will move to the next slide. Okay. This is, I am just skipping it because this kind of scenarios. Okay, definitely, suppose the scenario 1, an ACS 50-year-old man, rubber tapper, you see in the video. If they are coming and cardiologist in 60 kilometers away, what you have to do? You have to do a 10-minute tele-ECG program. Get the ECG in 10 minutes. If it's required, load it. A highway crash. At 2:30 a.m., 2:15 a.m., there is a two-wheeler crash, 8 minutes to primary health, family health center, half-strung, not fleet. What you have to do, you have to do be a primary care physician to do the stabilization, C-spine protection, and rather than blind refer this is looking at the scenario, this crash is likely to be a high mechanism. This will be have multiple injuries. Thinking about our Vandana Das scenario, etc. Even a stabbed one is intubated, but they forget to put it in a chest tube. These all actually killed that girl. So the referral is also required a pre-notification. Organophosphorus poisoning, 19-year-old person presenting with bradycardia and drowsy. What you have to do, you need a bulk stock. You have to start initiating a drop-in infusion. Here it is no immediate referral is not. It is not required if the patient is stable. You can delay a little bit. Airway can be delayed a little bit. Atropinization is mandatory, and also mental health leakage. About the last scenario, a landslide, 14 casualties like Wayanad or Idiki terrain. So what here it is, your people is the 14 people came there. You have to do a quick triage. What you can use is start triage. Start triage is based on airway, breathing, circulation, and disability. If the patient having airway or breathing, circulation, or anyone is affected, this will be put it as a red. Someone is walk in, they will put it as green, and in between people are put it is yellow. It's a simple triage. So this is the first thing you have to be a triage, even in a small center. It can be there, if it is in Wayanad, people will come to the Wayanad Health Center. Later only they will go to the Wayanad Medical College and other areas. So people also should know how to do that. So the last slide, the last slide on this, the primary facility. Okay, basically, we need some coordinated work, empowering the primary care system, plus engineering and protocol-based triage, seal car algorithm, placing this. Then again, training alone will not create. Training will alone create certificate only, but the training with after training, we have to give support for them whenever they need it. Then if they have some confusion, even a 1 hour, 1 day or 2 day training may not be, you will not become a big expert, but sometimes you will have a doubt. Even in the ECG, 100 ECG will come 100 different times. But definitely we should not miss something is a very serious item. Again, there is where the tele decision can be support. Again, the design district hospital, which is in the area like Idiki, Wayanad, and coastal belt, etc. They have to be upgraded accordingly. This is the okay. Before that, I will answer your questions. Prashantji.
Yes, sir. Sir, before that, actually, see, when you dream for something,
Yes.
when you are requesting for a flower, when you get a bouquet of flowers, it was something like your session. Okay. So I was searching for some guidelines or some training for general practitioners, but you gave a great plan and a visionary. You shared a visionary thought and action plan for the entire Kerala. That's really amazing. Now, before going for practical questions which I have received, my first request to you is, and your team, the people you have already trained, is that please share a set of videos where which we can circulate among the general practitioners, so that they can go through those videos and learn what all the basic clinical vignettes which they see and how do they have to respond. And I also request you to send algorithms which are simple and comprehensible for primary care physicians, so that we can share it to the grassroots level. Okay, that is my request.
Yes.
Is that okay?
Agreed. 100% agreed.
Thank you very much, sir. We will share through our WhatsApp channel and our channel networks through the entire Kerala. I'm sure Krishnakumar sir will definitely continue that mission. Yes. Sir, the primary question is, when a patient comes with an organophosphorus poisoning to the clinic of a ordinary general practitioner, should he refer immediately because if he don't have any emergency medicine, or should he do something at the primary level, like the one he was referring to was at least removing the dress and giving a new drug?
I agree. Yes, that is a wonderful question, and also organophosphorus poisoning is a big issue because all the hilly area, a lot of poison cases are there. So the primary physician should definitely the first step. First step is decontamination. But remember, this patient is to be airway is not compromised. The decontamination starting from just as you rightly mentioned, if our particularly the hilly area, primary centers and all, we need a small decontamination room. It's nothing like a small room, which is അവിടെ വെച്ചിട്ട് നമ്മൾ ഇവരൊന്ന് കുളിപ്പിച്ചെടുക്കാൻ പറ്റണം. നന്നായിട്ട് വെള്ളം ഒഴിച്ചിട്ട് അവനെ ഒന്ന് കുളിപ്പിച്ച് ക്ലീൻ ആക്കിയിട്ട് എടുക്കാൻ പറ്റണം. അതിനുള്ള ഒരു ഫെസിലിറ്റി എടുത്തു കഴിഞ്ഞാൽ കുറെ കാര്യം പിന്നെ റിമൂവ് ഓൾ ദ ഡ്രസ് പിന്നെ ദ വോമിറ്റേഴ്സ്. അപ്പൊ ഇതെല്ലാം ഒന്ന് മാറ്റി കഴിഞ്ഞാൽ ഫർദർ അബ്സോർപ്ഷൻ കുറയും. ആൻഡ് പാരലലി കമ്മിങ് ഇൻ ദ എൻട്രി ഇറ്റ് സെൽഫ് അവർ ഇടിയിലേക്ക് എടുത്ത് കൊണ്ടുവരായിരിക്കും. കൊണ്ടുവരുമ്പോൾ തന്നെ they have to look into that how the airway is like. If the airway is compromised or the patient is hypotension and other things, they have to taken into the ED. Then we have to be a bit more careful about the decontamination outside. But if the patient is unresponsive and airway is compromised, lot of vomiting, where we better to do the control airway first, because to prevent further aspiration, intubation. I don't know to what level they are okay, but this patient require intubation. And simultaneously, the drug that they can start is atropine. Atropine they can give because it is not a costly drug, not like an anti-snake venom. It is coming like in a vials. Vials are there. Vials are to be used and to be like that. അപ്പോൾ അത് നമ്മൾ പിന്നെ the endpoint, if at all they are referring, if the patient is with a compromised airway, better to put it in an airway control and initiate atropine and then send it. But if the patient is conscious and not much issues, only like in a few secretions and a few bronchi and all, the atropine will correct it.
Thank you, sir. Sir, you mentioned about the airway and then intubation during your talk, where the primary care physicians might be apprehensive about putting in intubation. Now you said something about a very practical intubation equipments where which do not demand much training. Can you elaborate on that?
Yes. Again, like, a patient, just I mentioned about the scenario, what you call, like, patient is repeatedly vomiting, and again, like in a lot of second, where the endotracheal intubation is the standard. But if these people are not very okay to put an airway and endotracheal intubation, they can use that two or there are three equipments. But the simplest one is the LMA. LMA is the laryngeal mask airway that they can blindly insert. That a few minutes of training or half an hour to 1 hour training is more than enough to make them to do that in the mannequin. And even they are not very good, not okay with the laryngeal mask airway. Then another device that is called the King's airway. I will share all the how to insert a King's airway and all the videos I will send to you. This King's airway
Okay, sir. That
is just a
sounds
blind insertion airway. Just if you can close your eye and you can do that. It will go 100% time. It will go to the esophagus. It is never to go to the trachea, but when inflating the cuffs, automatically two cuffs get inflated, and then this will seal both esophagus and pharynx, and you can start ventilation. It will work very well. Even in the paramedic can do that.
Sir.
Then
there is an
other thing, like, suppose a patient with this is not at risk of aspiration, but they like, suppose just unconscious, but airway, when you are giving the healthy and chillate, he is maintaining airway, but taking the hands off, again, he is getting into airways version, where we can do the airway adjuncts like, oropharyngeal airway or nasopharyngeal airway. That will work very well.
So there is a very interesting message in my personal chat box. You told about the portable ultrasound and the portable and the tele ECG unit. And his request is he searched in the website and he found that around 2 lakhs rupees for that this thing. And then to what extent? There are two questions on that side. One is tele ECG unit. How much is the cost? Is it possible to implement in a primary clinic or primary GP's clinic? Second thing is this portable, this ultrasound unit, does it require any formal, that PTPND Act and all things?
Yeah. Both are very catchy questions. First, I will talk about which one I want to talk. Tele ECG, I will talk. Tele ECG issue we can do because many of our projects, like in Ardhram projects, they have the fund for the government sector. For the private sector, definitely many of the private hospital, higher end private hospitals are, and again various cardiology people are very keen to do that. They will do their own cost. Whatever the cost, they will bear it.
What is the cost?
Maybe they will expect their referral. Even referral is not there. Even the big corporates and all, it is for them. It is a CSR. We can help them when, like, that private clinics like that. Government also we can help like that. But there are, like, we can tap the CSR fund. Even these people who are supplying the cardiac thrombolytics and all, they can ask to place this. This is not a big issue. This is a tele-ECG, and this, through the web-based, even the stroke detection unit and all, we can do that. And even through an AI augmented system, suppose, Prashant is sitting a junior doctor. Prashant want to intubate. Just I am telling an example. But if you want to intubate and you are not seeing vocal cord, now there are glasses. Smart glasses are available. So if you are keeping the smart glass, whatever you are seeing, that I can see from here. And I can guide you, Prashant. You just hold the laryngoscope little laterally and then advance it. Then I can, okay, now you can see this is the vocal cord. You just insert it. And I can confirm from here. That is possible. It is nothing, again, it is not a missing. Tele-ECG അതിനേക്കാളും simple ആണ്.
Sir, actually,
again, the stroke detection. Again, I will tell the primary care physician, suppose they are getting a call from their home. Sir, എൻ്റെ പേഷ്യൻ്റ് എനിക്ക് പിന്നെ സംസാരിക്കാൻ ഒരു ബുദ്ധിമുട്ടുണ്ട് എന്ന് പറയുകയാണെങ്കിൽ അത് വേണ്ട. സപ്പോസ് ദേ വിൽ ടെൽ സം കോൾ ടു യു. പ്രശാന്തിൻ്റെ ഒരു പ്രൈമറി അല്ലെങ്കിൽ എനി വൺ ഓഫ് ദം സിറ്റിംഗ് ദേ ആർ ഗെറ്റിംഗ് എ call from a primary, any ordinary patient from the home. What you can do, you can just ask what has happened. Then immediately you can do, simply you can switch on, ask them to switch on there, or you will tell, I will call you a video call. Is this okay? This question is very important. This video call is okay for you. I will guide you whatever you want. This is the consent. So you put it, the video call to the WhatsApp. It is nothing and luxury now. So you can, through the video call, you can ask the patient, say, suppose a stroke, you can ask the patient to smile. If the face is deviated one side, don't go to any other. This is a stroke. Or even it is okay, not okay, and ask them to put it the hand, supine and hold. It's a pronator drift. If the one hand is going down, it is a stroke. Or if you ask the simple name, if this is talking about Tiruvandar in terms of Trivandrum, then any one of these is a stroke. It is a clock keys, start to reverse direction. You can tell them quickly bring it to a hospital where CT facilities are available. It is very important. CT facilities, it is not going to a family physician. This case, all the time sensitive case. So this way, every physician, they can assess from the home itself. They can save the time. Then you ask about the PNDT and
that's USG, ultrasound
PNDT
regulation.
and USG. USG, definitely PNDT is essential. Because the Indian government and big people are thinking about all the female feticide is happening because of the ultrasound machine. Even implementing this, a lot of feticides are happening. That is a different story. But the PNDT Act is required. It will be implemented. It is required. Any of the person who is holding in a DMO register, they can take that machine in their name. Even a radiologist or a sonologist or whoever it may be. But the person, radiologist, is the people to sign it off. I mean, for that. And again, just I'm talking about through a computer. Now the fast machine is now available just like an iPad. Exactly an iPad. I don't know, you remember when our workshop is happening in Calicut, there was a ultrasound station. Supriya Madam did that. And where they bring it, just even if it's not a laptop, just a iPad. And the iPad, to the iPad, we can connect connect the probe. Probe is again a C connector, just like a C connector.
Okay.
And through this, again, high frequency, low frequency, all the probes will work there. Probably this is also like in around 4 lakh rupees, the cost will be there. But it is all the way the things are moving. But now the government also has got the funding to give an ultrasound machine in ED. District hospital, all the level, they have the funding is there.
Actually, for the information of the entire team, IMA CGP is, thinking deeply on the plans to empower general practitioners at the very grassroots level. Like, I was so happy to listen to the CSR model initiative of putting the TCG machine there. And similarly, we'll work on all possible options. Venu sir, you gave a lot of practical tips. There is a small question, which is very small, but still it is I should attend. That question says, you told about keeping aspirin and clopidogrel, and what is the dose? So it should be. I would like to listen. You to listen from your words.
Yeah, this is something like, if we are planning, because, usually we are loading, if it is a STEMI, for already, if the ECG shows like an ST segment elevation, at least two consecutive leads, or even a new onset of LBB, any of this considered as an STEMI, where we will give 300 plus 650 is okay. Because this patient will go for, should move early for this thing, what do you call it, primary or other thing. Even if it is a far away, suppose this a center cardiac, suppose it's happening in the Idiki interior, and the primary center is suppose roadblocks are there, few hours later, then we can do a thrombolysis from the primary center. No hurry. No issue. Only thing, there are some contraindication to the thrombolysis, like, high BP, again, a recent surgery, abdominal surgery or intracranial surgery, a recent arterial puncture. Like, if these are not, I will share the thrombolytic checklist also. People can do that. But stroke, we cannot do stroke without CT. First of all, CT is we are doing to rule out any bleed. Without ruling out bleed, if you give some thrombolytics or anticoagulant, means that bleed become it will expand and it will create all the mishaps. Patient will die in between.
Sir, actually, we will be discussing acute coronary syndrome in a short while in our testing forum itself. And then, sir, actually, there are very small other doubts which I am going to ignore, because you will be answering through some videos that you share. We will publish it through our channels. And sir, it's for I think everyone sitting here still now will understand it is a very big. Emergency medicine is not a small segment. It's it's something like learning radiology. Everything in medicine has to be learned by a radiologist to have a diagnosis. And similarly, emergency medicine team should know everything. But they are practically converting, practically saving many lives. And so you opened a very big box of learning, and it's a huge blessings for everyone. I don't have words to thank you, sir. And you sit there relaxed, keeping us, into a visionary track. And the Krishna sir was also telling, he will also continue the momentum that we are. Probably Krishna sir will be taking a bit definitely to a greater heights. So Venugopalan PP is a figure, from whom the world is, literally waiting more and more. And sir, we have a very big salute for your commitment, your families, their sacrifice. Because when you are moving on to this thing, I saw you, the madam, I know you, madam, she's also supporting very well. And we are proud of your family too, and your team. And whenever there are followers, whenever there is a leader, there are umpteen number of followers. And all the followers of Dr. Venugopalan, sir, we have a big salute. Thank you, sir. Thank you very much.
Thank you so much. It is a great opportunity. No other word. Hope that everyone is enjoyed the session. I thought make it a little different. That is the reason why an administrative ED is put it. So, telling about the CPR or telling about airway management, few videos and all is not a big issue for me.
Thank you. So, thank you very much. Thank you. So, friends, we'll meet again in next Thursday, 8 o'clock with a new segment, grand round series for general practitioners discussing comprehensive management of red flags in diagnosis of cancer. What are the steps, what are the essential do's and don'ts in cancer care in a primary care setting? See you next Thursday. Until then, bye and have a very good night. Sleep well, because sleep is the next best
Oh,
vaccine.
I also looking at a lot of new, so many comments are there now.
Yes, sir. Yes. Thank you very much. Sir.
Thank you so much.
Thank you, sir. Good night.
Signing off.